So now we'll be doing block 2 of NBME 20. Just gonna wait a little bit until some people join before we get started. I got a lot of positive feedback for getting started with the first part of NBME 20, block 1. Generally speaking, I'm looking at streaming every day between 12 to 3. It takes 3 hours to finish a block. So I did that 12 to 3 yesterday. Finished the block 1. I'm going to do it's 12 right now, so I'm going to do the 12 to 3 today also. Finish up block 2. And just keep going like that. So today is Thursday, yeah, so Friday and Saturday I should be done with NBME 20. Next week I'll start NBME 21. I'm going to NBME 22. And I'm thinking of the regular streams that I do. I'm up to neurology right now for the full FA playlist. That I'll probably try doing like evening streams whenever I have time. But that one doesn't need to be scheduled, so it's okay. Alright. So, block 2. We finished block 1 yesterday. We talked about all the explanations, all the different answer choices and stuff. So here we are at number 1 for block 2. So, a 12-year-old girl is brought to the physician for a follow-up examination. 3 months ago, she sustained a complex fracture of the left tibia, which required cast immobilization. The cast is removed. Examination of the left calf shows that it is smaller than the right calf. Which of the following processes in this patient's myocytes is the most likely cause of these findings? And then you have all these answer choices of what could have possibly caused that one leg, which was in a cast, to become smaller, right? That's really all that's happening there. So the correct answer here was polyubiquitination, but if you look at all the answer choices, anaerobic glycolysis, fatty acid degradation, glycogenolysis, and oxidative phosphorylation, these are all ways that you kind of make energy, right? Why did that person's leg become smaller? The one calf that was in a cast, why did it become smaller? It was just atrophy. Atrophy is a decrease in tissue mass due to decrease in size. She has decreased cytoskeleton degradation via the ubiquitin proteasome pathway and autophagy, plus decreased protein synthesis. Causes include disuse, which was her case because she's not using that calf. Denervation, which can also occur if you have a cast and it can actually denerve some of your nerves. Loss of blood supply, loss of hormonal stimulation, and poor nutrition. Any of these are various causes of things becoming smaller, losing weight, etc., etc. And it was just polyubiquitination. This was a really weird way to ask a question on this topic, but still, you could pick this answer because the others really don't have anything to do with atrophy. So the first thing was really realizing that this patient has atrophy of that calf. Number 2, a 56-year-old man is brought to the emergency department 30 minutes after the onset of severe chest pain while mowing his lawn. His pulse is 110 per minute, respirations are 20 per minute, and blood pressure is 105/70. Physical exam shows cool, clammy, diaphoretic skin. Now, I think in part 1, in the first block, we also had another question where the patient had cool skin or something like that. And when you see stuff like that, you're thinking of something within regards of shock. Alright, that question that we saw in block 1 was related to hypovolemic shock in a patient that was vomiting a lot. Here we have a patient with chest pain from mowing his lawn, right? Severe chest pain. Physical exam shows cool, clammy, diaphoretic skin, so he's very sweaty. 2 hours after admission, pulmonary catheterization shows a pulmonary artery pressure of 40/25. The left atrial pressure is 25. Compared with a healthy person, which of the following sets of pulmonary pressure changes is most likely in this patient? So you look at all the answer choices, they're talking about capillary hydrostatic, interstitial hydrostatic, and interstitial oncotic. So before anything, you had to figure out what kind of shock this patient is having, right, with the severe chest pain and cool, clammy skin. So you would understand that this patient must have cardiogenic shock, right? It has to do with the heart. So this patient has cardiogenic shock. Poor forward flow decreases cardiac output and increases the systemic vascular resistance. The PCWP, as they tell you, is high. and the central venous pressure. So basically what we're saying in that statement is that since blood isn't flowing forward, right, from the left ventricle into the aorta, from the right ventricle into the lungs, since that forward flow isn't happening correctly, blood starts backing up, right? So if the blood doesn't go from the left ventricle into the aorta, it's going to go back into the left atrium and then back up into the lungs. The pulmonary circuit has three parts: capillaries, interstitial space, and the alveoli. The extra blood increases capillary hydrostatic pressure, driving fluid into the interstitial space. Compared to the alveoli, the interstitial space now has more fluid, so there is more hydrostatic pressure and less oncotic pressure. Now fluid moves into the alveoli, causing pulmonary edema. And you need to make sure you understand that entire explanation, because it is without a doubt that you're going to get a question on cardiogenic shock on your step 1, and you're going to get a question, possibly 2 different questions, about pulmonary edema on your step 1. So you need to know the whole pathophysiology of how that happens, and they love testing on capillary, interstitial, and oncotic pressure. Right? They really enjoy that topic. It's discussed in first aid as well, but not really very much in depth. Right, so this is the part that talks about shock, right? We looked at this page yesterday. So this patient that we're looking at right now has cardiogenic shock, which is intrinsic, right? As opposed to obstructive shock, which is extrinsic. In obstructive shock, you have something like cardiac tamponade, or something that's embolized into the lung, something that happened outside the heart. Whereas cardiogenic shock, it actually, cardiogenic means that it was generated by the heart. So an MI or heart failure, anything, that's directly related to the heart. And that's the one that this patient has. Both present pretty similarly, but both are treated differently. Okay? So that's what this patient had. This patient had cardiogenic shock. And you can read about whichever shocks you want to read about by pausing the video anytime later on. The other thing you need to know is, I think it's talked about, let me see, where do they talk about it? Oh, right here. Yeah, capillary fluid exchange, right? So this is another topic where they don't talk too much in first aid per se. So, let me see if I can fit this. Okay, there you go. So these are all the notes that I have here for capillary fluid exchange. And this is the stuff that was the answer choices for the question we just looked at. Right? It's really important to know what, the way these arrows are pointing, what pulls things in and what pushes things out, stuff like that, from the capillary, and why they would happen. So generally speaking, it's pretty easy to understand whether there would be blood going in or not into these capillaries, but whether or not things are coming in or out is what you have to understand. And for our question, right, the answer was B. Capillary hydrostatic pressure will be high, interstitial hydrostatic pressure will be high, oncotic pressure will be low, right, because there's going to be more fluid than protein. This is a fluid problem, this is mostly a blood problem, blood backing up. Alright, so really good explanation right here. Make sure you really understand how pulmonary edema can occur. This one, a 92-year-old woman who was recently admitted to a nursing home because of progressive dementia, has large purpuric lesions over the dorsa of both forearms and hands. So 92 is extremely old, and she has dementia. And now we're talking about some weird purpuric lesions in an elderly patient at a nursing home. Okay. Her family states that she has had similar lesions on and off for years, and that, to the best of their knowledge, these lesions occur in the absence of trauma. The woman appears well cared for and has no other indications of recent or remote injury. Her platelet count is normal. Which of the following is the most likely explanation for the purpura? So since they tell you that her platelet count is normal, you know it's not petechia. Right? That was number one thing to understand. So at this point, when you look at all the answer choices, if any of them had something to do with petechia, you would take that out, and that would be D. Right? You would take out hereditary hemorrhagic telangiectasia because this patient doesn't have petechia. You get petechia when you don't have enough platelets, or if you don't have functional platelets, stuff like that. Abuse by a family member is immediately wrong because she's at a nursing home and everything from physical exam was just fine. Right? No indications of recent or remote injury. Autoimmune disease is a possibility. Platelet dysfunction is something you could think of. But atrophy of dermal collagen makes the most sense. She's 92. She's 92. She's really old. She's going to die soon, right? So it makes sense for her dermal collagen to be atrophying. There's really no reason for it to not. Many other things in her is probably also atrophying. So this patient The answer was B. It's not the same as actinic keratosis. This is called solar purpura. What she had is actually solar purpura. So what was wrong with this patient is just solar purpura, but it's very similar to the actinic keratosis. Actinic purpura results from extravasation of blood into the dermis. This phenomena is due to the skin atrophy and the fragility of the blood vessels in elderly individuals, which is exacerbated by chronic sun exposure, which is, high radiology. Actinic purpura lesions are located on sun-exposed areas like the arms, face, and neck. Skin atrophy in dermatoporosis is due to an alteration of collagen similar to that which is seen in osteoporosis. This pronounced skin atrophy caused by the photoaging makes the dermal vascular network very sensitive to the slightest trauma or shearing force. But you didn't even really need to know that. You didn't need to know solar purpura. They don't really talk about her walking around in the sun either. But she has large purpuric lesions on the dorsa, right, on the dorsa of her forearms and hands. And that's usually a giveaway that must be sun-exposed skin. Right, the dorsum of your hands is where the sunlight usually hits, not the under part of it. And they didn't say the forehead or anything, but if they had mentioned the forehead and the face also, then that would further give away that it's sun-exposed skin. And of all the answer choices, there was really no reason for anyone to pick autoimmune disease. It just wouldn't make sense. Just wouldn't make sense. Autoimmune disease would just be like, they would have to give you something for autoimmune disease. Plus, on top of that, the autoimmune disease wouldn't just be on the forearms and hands. It'd be all over the body in more places. Okay. Number 4, a newborn is born with a lethal chromosome defect. He is unable to suck sufficiently to maintain life. He has episodes of crying that occur every 2.5 hours and are relieved by tube feeding. Which of the following best describes the most appropriate clinical approach? So you basically have a newborn that's going to die, right? That's a lethal chromosome defect, means this newborn is going to die. There's no stopping it. The baby isn't able to maintain life. The baby cries, and every time he cries, you have to feed it. That's it. So now they tell you what's the best thing to do clinically. So A says feed by mouth only, feed by whatever means necessary to maintain comfort, give foods according to normal caloric requirement for age, withhold feeding because of the severity of the diagnosis. Now, so, you remember, in medicine, you never kill anybody, right? Even if this was an elderly patient, you would, when you have like a 70, 80, or 90-year-old patient who might have cancer and they're about to die in like the next 2 months or something, you give them hospice care until they die, right? You do everything you can to maintain comfort until they die. You give them opioids until they die because you don't really care about opioid addiction with that patient. They're going to die. Right, so whatever you need to do, you do. So the best answer that fits do whatever you need to do is B. Feed by whatever means necessary to maintain comfort. You have to maintain comfort. So that means if the baby needs to be given food every 2 hours by tube feeding, you're going to do it. And then the baby's going to stop, and then later again it'll cry. You just keep feeding it until it finally dies. Answer choice A, feed by mouth only, really doesn't fit in any way whatsoever. D really doesn't make sense because that's mean. That's really unethical, right? Withhold feeding until the baby dies. That's not cool. And C would be what you would do with a normal baby, not a baby that's got a lethal chromosome defect. Okay? So do no harm. That's basically the concept that's being tested here. Number 5, a 48-year-old woman comes to the physician because of a 2-hour history of dizziness and palpitations with a sustained, rapid, irregular heartbeat. An ECG shows atrial fibrillation. If amiodarone is administered, this patient is at greatest risk for which of the following adverse effects? So now you have to remember all the side effects of amiodarone, which is a class 3 antiarrhythmic. One of the most important side effects it had was the fact that because amiodarone is mainly iodine by weight, it can cause hyper or hypothyroidism, right? It can cause either one. And as soon as you see that answer choice, you pick it. It also has many other side effects, right? So we go to page 343, we can take a look. Because it is a pretty widely tested medication, and AMBOSS actually taught something new about it too that I really forgot about, I guess. So this is amiodarone, right? It's a class 3 antiarrhythmic. Amiodarone, ibutylide, dofetilide, and sotalol. These guys are potassium channel blockers, and potassium is related to the repolarization, phase 3. So you can see, remember to check PFTs because it affects the lung, LFTs because it affects the livers, and TFTs because it affects the thyroid. right? It can cause pulmonary fibrosis, hepatotoxicity, hypo or hyperthyroidism, because amiodarone is 40% iodine, and it can cause this bluing of the skin, the one that you see on the left, right? Because it can act as a hapten and deposit, causing photodermatitis, right? So it's kind of causes an allergenic thing. The only thing that I learned more recently about amiodarone, like I knew it, but I didn't really remember it, was that you look at all the class 3 channel blockers, right? Sotalol can cause torsades, ibutylite can cause torsades, dofetilide can also cause torsades, but amiodarone, although it can cause a bunch of shitty shit, it cannot cause torsades. Right, so there was a question that I believe Amboss asked, and they were like, which one of these medications would be best for this patient? And the main concept of the question was to make sure you give that patient a medication that won't cause torsades, will not prolong the QT interval, and it was just amiodarone. And I didn't even remember that because I thought all of them did, right? And amiodarone has so many bad side effects, you would think it also does it, but it doesn't. The only cardiovascular side effects amiodarone has is like heart block or heart failure, so not exactly torsades. All right, so that was a pretty easy question, very straightforward, I guess. A couple students didn't want to pick C because they thought amiodarone causes hyperthyroidism, but it can cause hypo also. All right. Number 6, a 71-year-old man comes to the physician because of a 6-month history of calf pain and discomfort when he walks more than 2 blocks. So there's a word for that. When someone has pain from walking, there's a word for that. Intermittent claudication. It's a phrase for that, not a word. Intermittent claudication. The word would be claudication, I guess. He is unable to walk farther than 3 blocks. The pain quickly subsides with rest. He also has hypertension and type 2 diabetes. Physical exam shows weak dorsalis pedis pulses bilaterally and an ankle brachial index of 0.67. The physician knows of a drug that would improve this patient's symptoms and walking distance by altering platelet function and providing direct arterial vasodilation. So now you want to think of a medication that does both things, and they kind of helped you out. This drug is most likely which of the following. So you look at all the medications and you think of which one of these can really cause vasodilation, and then you want to pick the one that also has something to do with platelets. So you look at abciximab. Abciximab, you have to remember the 6, 2 times 3 is 6. It's a GP2B3A inhibitor, right? So that's not something that's going to cause vasodilation. It does affect platelets, but it's not going to cause vasodilation. You don't pick A. You look at B, aspirin. Yes, aspirin gets rid of platelets. It gets rid of platelets, but it's not going to help with vasodilation. Clopidogrel was a cardiology medication, right? We looked at it in cardiology. Not really going to help with vasodilation per se. It's going to have an effect on the platelets because it's an ADP inhibitor, and you need ADP, but it's not really going to do much with vasodilation. Nifedipine was also in cardiovascular. That's a medication you actually can use for hypertension. It would help with vasodilation, but it has nothing to do with platelets. Then you just pick cilostazol, even if you forgot what cilostazol does. So these medications, the antiplatelet phosphodiesterase inhibitors, these medications increase cyclic AMP in platelets and inhibit platelet aggregation. The phosphodiesterase inhibition also helps with vasodilation. Cilostazol and dipyridamole are the 2 medications in this class, and they help with intermittent claudication, as seen in this patient, right? Calf pain and discomfort when he walks, as well as coronary vasodilation. Dipyridamole is actually the one that's used for the coronary stress test as well. All right, so that was all you had to do for this question. It was a slightly difficult question, but it was a very realistic question. Difficult only if you forgot what all the medications are, and pharmacology is only something you get good at by 2 things. 1, a lot of practice questions, and 2, by acting as if you are a doctor and really prescribing these medications to people you know. So either your parents, any other family members, people you meet. You can also do that with psych drugs. You might meet people and you're like, yo, that guy has X, Y, and Z issues. I would give him this. Just it's like a video game you're doing for yourself. You start prescribing people medications in your own mind, and by doing so, you start becoming more like a doctor, where you're prescribing medications, so you better know the side effect, you better know how it works, you better know who it's good for, and so on. So it's one more thing that you can definitely do. And, I definitely know people who have pain from walking long distances, or people who get tired from walking long distances. That would be a different medication. And you have to remember the cilostazol stuff, because it's a really interesting medication, being that it does both things, the platelet stuff as well as phosphodiesterase inhibition. So when you come here, antiplatelet phosphodiesterase inhibitors, these guys are really special medications. These are pretty cool because phosphodiesterase inhibitors are usually only things like the Viagra stuff, that's basically it. But here you have antiplatelet ones which also inhibit platelet aggregation. It's going to be every day from 12 to 3, basically, New York time. Alright, so that was, yeah, I did have power issues. The day I was actually supposed to stream, I had power issues, yeah. So I started yesterday. I was supposed to start 2 days ago. So that was it for number 6. Okay, number 7. Removal of the thymus at birth results in severely impaired immune responses. However, if the thymus is removed from an adult, little, if any, deficit in immune responsiveness occurs because of which of the following reasons? Surprising how many people did not really know the answer to this. So it was actually really surprising me how many people didn't know this, and I guess it's something that's not really spoken of much with the thymus, right? Because everyone thinks of a really infant person, that person shouldn't really have a thymus because you don't want to see that thymic shadow, and you definitely don't want to see it as an adult. But not many people really understand how all of that really works and what's the role of the thymus and stuff like that. So yeah, if you remove the thymus from a newborn at birth, they're not going to be able to have mature T cells, right? And that completely makes sense. But if you take it out of an adult, it doesn't do anything. So what's the problem here? Well, if you look at all the answer choices, so A, antibody-producing lymphocytes are the most important cells for adult immunity. I mean, they're important, but they're not the most important. That's not true. The bone marrow can take over the role of the thymus. Definitely not true. The bone marrow is where you make B and T cells, but T cells have to go to the thymus to become mature. Most antigens that elicit protective immunity in adults are thymus independent. That's not true either. You need your T cells to be matured in the thymus, so that's not going to happen. Thymic lymphocytes produced before the thymectomy are long-lived. And then E, thymic nerve cells sequestered in lymph nodes replace the need for thymic lymphocytes. D and E are pretty similar answer choices, and I guess someone that is really trying to be complicated would pick E, but D is a fact. D is an actual fact. Thymic lymphocytes produced before thymectomy, all the T cells, all the mature T cells you already made in the thymus, actually are very long-lived. So they'll be around still, and until they run out, you're going to be okay. This adult will have symptoms though once those mature T cells run out too. So over here, by age 75, the thymus is little more than fatty tissue. Basically, it's useless. Fortunately, a thymus produces all of your T cells by the time you reach puberty. They are long-lived, and that's why you can lose your thymus without impairment of your immune system. The naive T cells can live for up to 9 years and are stored in lymphoid organs. So a patient who gets a thymectomy will be fine. Right? And you get a thymectomy in myasthenia gravis because myasthenia gravis is related to getting a thymoma. Everyone's favorite stuff, Hardy-Weinberg. So the frequency of an autosomal recessive disease in a population is 1 out of 1,600. A deletion has been identified that accounts for 80% of the mutations at this locus. 20% of the mutations result from point mutations. The frequency of deletion carriers in the population is closest to which of the following? And then at this point, people are just going to be like, what is this 80%, 20%? What are we talking about here? Well, you really just want to take it very, very systemically. First, find your P and Q. Find all of that, right? It's very, very systemic stuff. Find the P, find the Q, get your Hardy-Weinberg equation stuff together, then tackle the question. Because what is the question? They just want to know the frequency of deletion carriers, right? And a deletion has been identified that accounts for 80% of mutations. 20% of those mutations result from point mutations. So you got to figure out what deletion they're talking about too. The question isn't exactly very, very precise, but you got to get started, right? So take the square root of q squared, right? They gave you the q squared. Autosomal recessive disease in a population is this much. So if you take the square root of that, you're going to get q is 1 over 40. Calculate the frequency of the dominant allele with p plus q equals 1. So that means p is 39 over 40. And when something like this happens on your test, right, 39 over 40 is pretty much 40 over 40. So you can approximate that to be a 1 and work with that. They are telling you to calculate the frequency of the disease carriers, which is with the equation 2pq. Right? The heterozygotes are the carriers. They want only the disease carriers in which deletion is present. To calculate this, use the q value, 1 over 40, and multiply by 80%. And this should give you 0.02. Finally, calculate for 2pq. That's a 2 times p times q. You get 0.04, which is 1 over 25. And you're done. Right? 1 over 25. The answer choices are actually far enough from each other. The answer choices are actually far enough from each other for you to be able to estimate an answer. But realistically speaking, the way they phrased this question was what was most confusing for people. They didn't want just one thing. They wanted a very, very specific, weird thing. And since 80% of the people had mutations, and that was the 0.02 you got, that's all you had to work with. You didn't really need to worry about 20% of the mutations resulting from point mutations. You didn't care about that. All you cared about was whether or not people had mutations. Right? The frequency of deletion carriers in this population is closest to what? Well, a deletion is only in 80% of the people. That's it. So you get the people, and then you get 80% of it, and you're done. All right. So that was a pretty weird question. I'll definitely give it that. It was a weird question, but if anything, you want to be able to at least calculate the q squared, 2pq, all of that stuff. Make sure you know how to do that. At that point, you should be able to answer most questions, at least the ones that you'll get on step 1. I don't feel like NBME. I don't feel like step 1 would have asked you this question, but you should be able to solve it. You should be able to solve it, and stuff like this. It's not that it's hard; it's that you're out of practice. If you're having difficulty solving it, you just haven't practiced it enough. All right, so spend some time with Hardy-Weinberg stuff. You could find a whole Q bank of Hardy-Weinberg questions and actually solve them. Number 9, a 10-year-old boy has a palpable mass in the ventral midline of the neck, just inferior to the hyoid bone. This structure most likely developed from which of the following embryonic tissues? Very interesting question, right? First, you have to figure out what the structure is, then figure out where it comes from embryologically. So page 347 discusses thyroid development. You know this is related to the thyroid. Right? And this person has a ventral midline, right? It's not on the side. There's a difference when it's in the midline and when it's on the side. This patient has a thyroglossal duct cyst. The thyroglossal duct may persist and result in a thyroglossal duct cyst occurring in the midline near the hyoid bone or at the base of the tongue. Thus, will classically move up with swallowing or tongue protrusion. That's how you figure out if it's a duct cyst or not. The foramen cecum of the tongue is the normal remnant of the thyroglossal duct. Now, figuring out where that comes from, well, that was A, endoderm of the foramen cecum. They actually put foramen cecum there, so it was a really good supporting answer choice. They didn't just put endoderm. Endoderm are the fourth pouch, second pouch, and third pouch. Neurocrest, first of all, you could just knock out C and D because this is not neurocrest related. Right? But B, endoderm are the fourth pouch. Well, you have to remember what the fourth pouch does and where that's related to, and is not related to your thyroglossal stuff. Right? The third and fourth pouches are related to parathyroid, but not exactly the thyroid. So page 347 is where they talk about just the thyroid development, and you can see the same stuff again. Right? So thyroid migration, you have your foramen cecum. The thyroid, as it migrates, can be stuck as lingual thyroid, sublingual thyroid, prelaryngeal thyroid, normal location. Right? And the other thing that you have to compare it to is a persistent cervical sinus. This thing does not move with swallowing. It's usually at the side of the lung. Side of the throat. Right? It's not in the midline. It's going to be on the side of the neck. So persistent cervical sinus is a different thing. Right? And that's what you have here, the cervical sinus right here. It would be a pretty big protrusion on the side of the neck, and it's not going to move with swallowing. That's your pharyngeal cleft cyst in the lateral neck, and you're done. Right, pharyngeal cleft cyst in the lateral neck. But our question was a thyroglossal duct cyst. Right, midline neck mass, moves with swallowing. It's just a thyroglossal duct that stayed and it made a cyst. Comes from the foramen cecum. So, pretty straightforward question, but again, if you don't remember it, it becomes hard. Number 10, a 46-year-old man has dyspnea or orthopnea and a mid-systolic murmur that is best heard over the cardiac apex. An ECG shows a left atrial abnormality. Echo shows an enlarged left atrium and a normally sized left ventricle. Which of the following is the most likely cause of these findings? Starting to feel like I'm about to get sick. So what were the findings? So you just had left atrial abnormality. Echo showed an enlarged left atrium and a normal sized left ventricle. What could have caused it? Okay. So if the left atrium gets big, but the left ventricle is a normal size, it usually means that the left atrium is just having to work really, really hard, right? Or the patient is extremely old, which is not true here. The patient is not extremely old. So you look at all the answer choices: aortic regurgitation, aortic stenosis, mitral regurgitation, mitral stenosis, ventricular septal defect. A lot of people picked mitral stenosis. A lot of people. And there was one thing that really helped you not pick that answer choice. Why would people pick mitral stenosis? Well, if you have mitral stenosis, your left atrium has to work really, really hard to open the mitral valve into the left ventricle, right? And in working really, really hard, your left atrium becomes big. So I can see how you would end up picking that. But mitral regurgitation can also make your left atrium big, because what happens with mitral regurgitation is that blood comes back into the left atrium, and then you get new blood from the lung into the left atrium also, so you're always filling the left atrium up a little too much and it expands, right? Both are two different ways that you can make your left atrium bigger. The aortic stuff were answer choices you could have immediately canceled out, because any issues with the aorta would affect the left ventricle, right? You always affect the ventricle right before or after the valve. And the left atrium is two ventricles away, right? It's two places away from the aortic stuff. The aortic valve is only related to the aorta and the left ventricle. And we're not talking about either of those guys. Left ventricle is normal. So how would you pick between mitral stenosis and mitral regurgitation? Well, I made up this thing called D-arms, right? D-arms was the Dining arms kind of thing. So D-arms is supposed to remind you that diastolic, D for diastolic murmurs are aortic regurgitation, right, and mitral stenosis, right? Remember, the D-arms reminds you diastolic murmurs are aortic regurgitation and mitral stenosis. And this patient has a mid-systolic murmur, right? Not a diastolic murmur. This patient has a mid-systolic murmur, heard at the apex. They told you that. The only answer choice worth picking now is mitral regurgitation, which is super common. Everyone gets mitral regurgitation at some point in their life, right? So mitral stenosis, although this made sense because the left atrium is big, it's not the correct answer because this patient has a mid-systolic murmur. To have mitral stenosis, you would need a diastolic murmur. And that was the trick here. So it was a hard question in the sense that it's a tricky question. Number 11, a 2-month-old girl is brought to the emergency department by her parents because of a 6-week history of constipation. She has also had poor feeding, sleepiness, and yellowing skin during this period. Her parents are migrant workers, and she has not received routine medical care. Physical exam shows lethargy, hypotonia, jaundice, large fontanelles, macroglossia, and an umbilical hernia. Which of the following is the most appropriate next step to establish diagnosis? Now, that physical exam pretty much gave away what's wrong with the baby. But also think about the fact, 2-month-old girl, 6-week history of constipation. So for a month now, she's had constipation. You don't necessarily get constipation as an infant unless you're a newborn. A newborn might not even pass meconium, right? And that's different. That starts from the first day, though. This baby is now 2 months old. So whatever happened developed recently. It's not something that the baby was born with. So if the baby wasn't born with it, you can take out chromosomal analysis as an answer choice. And then you could start looking at your other answer choices. And when you get to thyroid function test, it should ring a bell for you for cretinism. And you have to remember all the things they describe, right? The 6 P's of cretinism: potbelly, pale, puffy faced, the protuberant tongue, all of those things they have. Page 365. We can go take a look at it. So this is the picture for it, right? This is exactly what we're being described in our image in our question too, and it's the 6 P's: pot-bellied, pale, puffy face, protruding umbilicus, protuberant tongue, poor brain development, because the thyroid is related to everything, and that's what this baby has. So why did it take so long for the constipation to kick in? Is because the maternal thyroid hormone was there in the beginning. Once the maternal thyroid hormone ran out, now the baby is exhibiting symptoms of hypothyroidism, cretinism. Okay, so you would just do thyroid function tests and you're done. So thank God that step 1 and NBME are all multiple choice tests. When you see an answer choice that seems plausible, it helps you consider more possibilities. Right? Each one of these helps you consider a possibility. Like muscle biopsy would help you consider some of those, like things like McArdle and stuff. Those glycogen storage diseases. This is not a glycogen storage disorder at all, so you wouldn't pick that. MRI of the brain really doesn't seem necessary for this baby. Measurement of serum phenylalanine concentration was one of the biochemistry disorders, and this isn't that either, so you're done. Number 12. 60-year-old woman has prolonged apnea following general anesthesia. So at this immediate point, you're supposed to figure out, before you even go on to further things, what they could have used for anesthesia here. Plasma cholinesterase activity is not normal. Which of the following agents is most likely responsible for the prolonged apnea in this patient? Right, so apnea. So which anesthesia of all of these anesthesias, which anesthetic could you give that could have caused prolonged apnea? You go through all the answer choices. Bethanychol is not exactly something you use for anesthesia. Nor is carbachol, right? These are all acetylcholines. These are all things that work like acetylcholine. That's what they have choline in it. So you could just, bethanychol, there's a statement in first aid, right? Like, call me to activate your bowels and bladder, something like that. And carbachol is a carbon copy of acetylcholine. So these two guys are not going to be the answer. They're just muscarinic things. Dibucane and halothane and succinylcholine are things you can consider. But even dibucane, you should remember what all the canes are for, and that's not a possible answer choice either. So ultimately, you would come down to D and E, halothane or succinylcholine. The next sentence, telling you that cholinesterase activity is not normal, pretty much gave away the answer as succinylcholine. But these things, this mentality, the giveaway and whatnot would only happen if you know things. So you have to go back to 595. You would actually check out the neuromuscular blocking drugs. Now, let me see. There's where did they talk about? Yeah, succinylcholine. Succinylcholine does a bunch of things. There's always this UL question about the train of 4 stimulation. They love bringing that up. Amboss also had a question of the train of 4. Tissue distribution and lipophilic drugs. Like, there's so much you need to know about anesthetic drugs, right? Local anesthetics. All the canes are local anesthetics. They're not going to do systemic symptoms, right? Esters. And the ones that have 2 I's in it, those canes are amides, whereas 1 I is an ester. So you really have to spend a lot of time here making sure you understand what's happening. And there's so much to know about with the anesthetic general principles. The book doesn't talk about it that much. I have a lot more notes on it. When we get to neuropharmacology, hopefully by the weekend, we'll discuss all of this at that point. But there's so much to know, and once you actually understand it, you won't have any trouble remembering it. So this patient was taking succinylcholine, right? Succinylcholine is a strong acetylcholine receptor agonist that produces sustained depolarization and prevents muscle contraction. And because of this relation to acetylcholine, they put those other answer choices here, bethanychol and carbachol. Right? But it really shouldn't have confused anybody, because you never think of those 2 medications when you think of anesthesia. So strong acetylcholine receptor agonist produces sustained depolarization and prevents muscle contraction. So you're anesthetized. You're going to have flaccid anesthesia. Succinylcholine is not metabolized by acetylcholinesterase, so it stays at the receptor for a long time. it is metabolized by plasma cholinesterase, also known as pseudocholinesterase. And then you have to figure out, because the book doesn't tell you any of that. Then they go on to tell you about phase 1, where the block is going to be potentiated by cholinesterase inhibitors. There's no antidote for phase 1. Phase 2 is where you're repolarized now, but you're still blocked. So the acetylcholine receptors are available, but they're not sensitized. They're desensitized, so you're not going to respond. Maybe reversed with cholinesterase inhibitors now. Right? Cholinesterase inhibitors only work during phase 2, and that's another thing you can get questions on. So a lot of things like that, muscle paralysis and surgery or mechanical ventilation, selective N-M-nicotinic receptors at neuromuscular junctions, but not autonomic receptors, right? So the autonomic receptors are the one where your normal acetylcholine stuff, like carbachol and all of that would work. So for this patient, the answer was just succinylcholine because they tell you that the plasma cholinesterase activity is not normal. That means plasma cholinesterase activity or pseudocholinesterase is working too much. So I wrote here, the duration of action of succinylcholine is determined by its metabolism by plasma cholinesterase. So if there is abnormal plasma cholinesterase, it will lead to a delayed metabolism of succinylcholine, as well as marbaserum, heroin, and cocaine, a couple other things. But you really only need to know the succinylcholine stuff. So since this patient did not have a good amount of plasma cholinesterase, she did not get rid of her succinylcholine, and it caused prolonged anesthesia. So she has prolonged apnea. That's it. That's all this was. But it was a very hard question in my opinion, because not many people tend to remember the plasma cholinesterase stuff. It's not really in first aid. They don't really mention it in first aid. I wrote this here, but they don't really have it mentioned in first aid, right? So succinylcholine is not metabolized by acetylcholinesterase. It is metabolized by plasma cholinesterase, which is pseudo or fake cholinesterase. Really important to remember that. Right, so succinylcholine is pretty special in that manner. Halothane, let me see where that is. Halothane is one that you breathe in. Yeah, inhaled anesthetics, right? Halothane. And that, very fair answer choice, very confusing answer choice. Everyone's going to pick it because halothane causes respiratory depression. But she's not having respiratory depression per se. She's just having prolonged apnea. And I can see how the two things fit together, but the main thing is halothane would have nothing to do with cholinesterase activity. Halothane is not an acetylcholine. It does not work like acetylcholine. Halothane is an inhaled anesthetic that actually gets into your tissue after you breathe it in, and it has nothing to do with acetylcholine. So since they mentioned acetylcholine in the question, you had to write off halothane as a possible answer choice, and that was it. Alright. 13. A 45-year-old man comes to the emergency department because of a tooth abscess. He has not seen a physician or a dentist in over 10 years. He lives alone, is unemployed, and receives income from an inheritance. When asked what he does with his time, he says that he reads books on physics. He has no friends, maintains minimal contact with relatives, and says that he is really quite comfortable. Examination shows no symptoms of a thought disorder, which of the following is the most likely diagnosis. And then you start looking at all these answer choices, and these are all personality disorders. Now, if you've seen my psych videos, I did a really good job, even in the old one, discussing different personality disorders. And the new one is going to be even better because I made some changes and I added more practice questions. But what is this patient doing? So there's nothing per se wrong with the patient, right? He likes living alone. He likes being isolated, which is perfectly fine. And he's not doing anything awkward. He's reading books on physics, which is actually truly fun to do. Like, if you enjoy it, you enjoy it. He reads books on physics, and he's comfortable. He didn't say he's trying to create something weird, talk to God, go on some crazy mission, anything weird like that. Getting a tooth abscess can happen. Maybe he's infected by something, and he hasn't really seen a doctor. Maybe he has diabetes too. So it's okay. Nothing's wrong with him. So now, of all these personality disorders, which one of these guys is the one that likes to live alone and is perfectly fine? You want to think of an android when that happens, right? An android is a robot that would not mind living alone. He's going to be perfectly fine. He's not going to be crazy or whatever, right? He's not going to do any kind of psychologically unacceptable behavior. And when you think of an android, you think of schizoid, and you just log that in. That's it. It's just anyone who likes being alone. It's so easy to confuse that with avoidant, right? It's also really easy to confuse that with antisocial. But antisocial and avoidant are not people that truly like living alone. That's not what's really happening there. This patient is voluntarily living alone and is doing just fine. There is nothing frantic or far-fetched about the person. He is like an android, so you think of schizoid. That's it. Androids are robots, and there's nothing too far-fetched about them either. They'll just sit there in a corner all day not doing anything, and there's nothing wrong with that. Some of us wish we could do that. It'd be great. So when you look at the cluster personality disorders, right? Cluster A personality disorders, you want to think of this guy from Wizard of Oz, the Tin Woodman. He's like an android. He was not weird in any way whatsoever. Granted, we're not talking about reality. And he just did his own thing. He didn't mind being alone. He was like a scarecrow. He was just doing his own thing. Right, so schizoid, voluntarily socially withdrawn, limited emotional expression, content with social isolation. The limited emotional expression is the other reason I say think of a robot. Robots will not have, I mean, maybe in the future they will, but robots don't generally have emotional expression, right? Schizotypal is the other thing in cluster A, but schizotypal is not schizoid. So you got to make sure you keep that in mind. Eccentric appearance, odd beliefs, or magical thinking is the other reason I ask you to think of him. He is eccentric, right? He looks weird. This is not how a normal human would look like. He does think of, he reminds you of odd beliefs and magical thinking. It's the Wizard of Oz. That's a magical thing at all. And interpersonal awkwardness. So this is the other cluster A. Cluster A stuff is all schizo. So schizoid and schizotypal is all you have to remember. Once you remember schizoid, you remember schizotypal, and you're done. Cluster B was Cardi B. So all the Cardi B stuff, antisocial, borderline, histrionic, narcissistic. She might not actually be any of these things, but you just gotta attach that to her and remember it, right? So dramatic, emotional, erratic, mood disorders, substance abuse. These are all things that a lot of big time celebrities do. So it's okay to use her to remember cluster B. And cluster C was this guy, right? Sheldon Cooper from Big Bang Theory. Hilarious, genius guy. He's just a scientist. If you haven't seen Big Bang Theory, first of all, you're missing out. And second of all, he's just a scientist in that show. He's a very, very intelligent physicist. And he has these things. He is avoidant. So he's very, very sensitive to rejection. Like if he has a very intelligent idea and you tell him you don't like it, he's just going to write you off as the stupidest person on earth. Like there's no way you could be, rude to him. So that's avoidant. Hypersensitive to rejection. Desires relationships with others though. Right? And you compare that to schizoid. Schizoid is fine being alone. Schizoid patients are not dying to be with anyone. Avoidant is avoiding people because they're scared of rejection, but they do want to be with people. Obsessive compulsive personality disorder, which is what a lot of people have, is literally like OCD, but it's a personality. So it's egosyntonic, which means that right? Behavior is consistent with one's own beliefs and attitudes. Right, whereas in OCD, you know that what you're doing is kind of extra. He never thinks he's wrong. So if he wants something done in a certain way, that's his obsessive compulsive personality disorder, and it's egosyntonic. Whereas OCD is ego dystonic. Dependent. Another thing that Sheldon Cooper does is that he has an excessive need for support. Right? He needs everyone to be like, Sheldon, you're an amazing person, you're so smart. And all of that just fits in perfectly. If you just watch a couple of clips of Sheldon Cooper, you will start seeing the cluster C personality. Cluster B is super easy to memorize as well now with Cardi B. And the Tin Woodman of Wizard of Oz for cluster A. So this guy was the Tin Woodman. He literally lives in the woods. He's pretty much just doing his own thing all alone. And he's perfectly fine. There's nothing wrong with him. Okay, so schizoid. Number 14, a 59-year-old man develops fatigue and decreased appetite 3 months after receiving a mechanical aortic valve replacement. So you already kind of know what's wrong. His pulse is 88, respirations are 12, blood pressure is 140, he appears tired because of anemia, physical exam shows mild scleral icterus because of anemia, jugular venous pressure is 8, carotid upstrokes are normal, lung fields are clear, cardiac exam shows a crisp prosthetic valve sound and a grade 2 out of 6 decrescendo diastolic murmur at the left sternal border. Abdominal exam shows no tenderness, normal liver size, normal bowel sounds. Like, I love how NBME loves giving you mad information when a question is actually really easy. You were done with the question right after the first sentence. 59-year-old man develops fatigue and decreased appetite 3 months after receiving a mechanical aortic valve replacement. Mechanical aortic valves can cause macroangiopathic anemia because they can actually cause hemolysis due to shearing forces and break the red blood cells as they go through the valve. Hemolysis. You would just pick C and move on. Right? But if we keep reading, abdominal exam shows no tenderness, normal liver, normal bowel sounds. Lab studies show a total bilirubin concentration of 4, direct bilirubin of 1. Right? So he has a lot of indirect bilirubin. Which of the following is the most likely cause of jaundice in this patient? And then a lot of people would just pick, cholestasis or hepatocellular disease, and that would be it for them because of all the extra shit they read. But in all reality, he has jaundice because of the shearing forces destroying his red blood cells. Excess indirect bilirubin is too much for him to actually metabolize quick enough. It's not that his liver isn't working. It's just there's too much to metabolize for his liver enzymes to actually make into direct. Right? Take all the indirect and make it into direct. So that's really all there was. There was nothing else to it. If they gave you a blood smear, you would see schistocytes on the peripheral blood smear secondary to the mechanical destruction of red blood cells. So if you see a question that keeps going on and on and on and gives you mad information, make sure you revisit what the real problem was. Why did the patient come in? Right? The patient came in because of a mechanical aortic valve replacement, and that's the key point to focus on. Not focus on the amounts of bilirubin or his carotid upstroke or any of that other stuff. Number 15, a 4-week-old infant is brought to the emergency department because he has vomited after every feeding for the past 2 days. So now, past 2 days, that means that the first 3 weeks the baby was fine. The most recent episode of vomiting was very forceful, with regurgitation through the nostrils. Physical exam shows mild abdominal distension with visible peristalsis. Which of the following is the most likely explanation for these findings? Okay. So now, if you look at all the answer choices, duodenal atresia, gastric volvulus, pyloric stenosis, intussusception, Meckel diverticulum, Zenker diverticulum, and TEF. Okay, you can knock out TEF because that would actually have cyanosis and choking spells, right? So, I actually wrote everything. So let's look at it. This baby has pyloric stenosis. If you couldn't figure that out as soon as you read it, then after this question and the explanation, you should go ahead and check that today and make sure you understand these, because GIT is, in my opinion, one of the easiest chapters of first aid. It is one of the easiest chapters you can get questions on, but again, you have to know your things. Most common cause of gastric outlet obstruction in infants, you get a palpable olive-shaped mass in the epigastric region. You will have visible peristaltic waves and non-bilious projectile vomiting at 2 to 6 weeks old, right? And they told you that the vomit was very forceful. That's projectile vomiting. They can't say projectile vomiting because that would be a giveaway. If you do an ultrasound, you'll see a thickened and lengthened pylorus, and the treatment is just to do a pyloromyotomy. You cut that shit and make it a little more open. Now, why are the other things wrong? Well, duodenal atresia is associated with Down syndrome, right? And sure, they might not give you Down syndrome, but what else would they have to give you? Well, there would not be any peristalsis because you have atresia. You actually have atresia of your duodenum. You lost your duodenum. How would you have atresia? How would you have peristalsis? TEF you can cancel because with tracheoesophageal fistula, you're not exactly doing the right amount of oxygenation. So you would have choking spells and cyanosis. Things from your esophagus are going into your trachea, so they're going into your lungs, so you're not breathing correctly and you're going to keep coughing. Zenker is elder Mike. These are elderly people. The pharyngoesophageal, that's the smelly breath and everything else in the back of the neck. Meckel diverticulum can occur in an infant, but that would have right lower quadrant pain and hematochezia, blood. Right? You would also need the question to tell you something like finding gastric tissue in another part of the body, right, outside of the stomach. Intussusception is painful, again with bloody stools. We don't see anything bloody here. No bloody stool, no bloody vomiting. So you cancel out intussusception, you cancel out Meckel. Volvulus would not have peristalsis either. Right? Gastric volvulus, your intestines are all wrapped up, so everything isn't going to flow correctly through your intestines. So A and B immediately went away because they told you visible peristalsis. A and B go away. And then intussusception is painful. Meckel diverticulum has blood. Tracheoesophageal fistula has the hypoxia. Super easy to cancel everything out. You just stick to hypertrophic pulmonary stenosis, and being 4 weeks old fits that, right? The only reason it didn't occur earlier was because maybe most of the feedings were just purely liquid. And oftentimes this muscular, where is it? The palpable olive-shaped mass, as the baby gets bigger, the mass actually becomes more muscular, so the obstruction becomes more strong. So it doesn't have to happen within the first 2 weeks, but it can. 16. A 23-year-old woman who was diagnosed with Sjogren's syndrome 6 years ago comes to the physician because she has had burning pain in her toes for the past month. She rates the pain as a 3 on her 10-point scale. She uses capsaicin cream as needed for the pain, which has produced partial relief. Medical history is otherwise unremarkable. Vital signs are within normal limits. Neurologic exam shows decreased perception of temperature over the feet bilaterally. Sensation of vibration, proprioception, reflexes, muscle strength, muscle tone, and bulk are normal. Like so much extra shit, right? Which of the following neurotransmitters is the most likely mediating this patient's pain? So if you actually started, a lot of people do this thing where instead of reading from the beginning, they'll read the last sentence first. So if you actually started here, you already know the answer. Which of the following neurotransmitters mediating pain? Substance P. The other guys don't mediate pain, so you could just pick that and move on. But of course, you're still going to be curious, or you want to be safe. So you'll read the rest of the question, and you'll realize that they just gave you mad shit for no reason in the whole question. And you would come back and pick substance P. The only place you might be confused is you might not know what enkephalin is, right? So, and enkephalin is a pentapeptide, 5-protein peptide, involved in regulating nociception in the body. And nociception was not an issue for this patient, so you're good. The enkephalins are termed endogenous ligands, as they are internally derived and bind to the body's opioid receptors. And first aid does mention enkephalin one time. Not that important, nor is it high yield. But pain is substance P, right? An antagonist of substance P that blocks the neurokinin 1 receptor is used as an antiemetic, which was aprepitant. That's a medication that's in first aid too. Number 17, a 3-year-old boy is brought to the physician because of a 1-month history of pale skin. His parents are of European descent. He has no personal or family history of major medical illness. Physical exam shows pallor. Lab studies show low hemoglobin, low hematocrit. Mean corpuscular hemoglobin concentration is fine. Mean corpuscular volume is also fine. But if you have a low hematocrit and low hemoglobin, that generally means you're not making enough red blood cells, right? A photomicrograph of a peripheral blood smear is shown. Genetic testing is most likely to show which of the following in this patient. So you look at it, and you see some of these red blood cells are a little, they're missing the central pallor, right? This one has it, but the others are all practically missing it. Don't pay too much attention to this guy. It's not really relevant. Then you look at your answer choices, and you're seeing answer choices sort of related to 2 diseases. One is related to ankyrin, which is going to be for the shape of a red blood cell, like spectrin and stuff like that. And then alpha thalassemia, beta thalassemia. So, what are you going to pick? Well, when you look at these red blood cells, right, they're really, really spherical. They're really big and spherical, like this guy, this one here, right? There's a couple. So the histology is of spherocytes, small spherical cells without central pallor. Hereditary spherocytosis is due to defect in proteins interacting with red blood cell membrane skeleton and plasma membrane. So ankyrin, band 3, protein 4.2, or spectrin. Mostly autosomal dominant inheritance, so heterozygous mutations, since you only need 1 mutant allele to get the disease. Right, so heterozygous mutation in the ankyrin gene and you'd be done. Right. Which of the following is most likely? Could it be a homozygous mutation in ankyrin gene? Maybe, but he has no personal or family history, so I don't see how he would have homozygous mutation. All right, most likely a heterozygous mutation. Now, as far as alpha and beta, this is definitely not alpha thalassemia. This is definitely not beta thalassemia. The mean corpuscular hemoglobin concentration will be normal because these red blood cells are normal. They're normal, they're just in weird shape. The only issue with this is the shape. Without the correct proteins, ankyrin, band 3, protein 4.2, and spectrin, you can't make the red blood cell become a donut, so you lose the central pallor. Spectrin and those guys give you the correct central pallor. If we go back and look at it now, let me see, in Hem-Onc pathology, and we look at this stuff right here. Right, so we're looking at the thalassemias are one thing. They're going to have a low MCV, which was another issue actually, right? The mean corpuscular volume was also normal. So you have to understand, like, mean corpuscular volume tells you microcytic or macrocytic, or is it just normocytic? And this patient's thing was pretty much normocytic. So if you're normocytic, then you can just figure out, like, it's got to be something that's causing hemolysis, either because of something intrinsic, which is this patient, hereditary spherocytosis, or something extrinsic, which is, usually autoimmune, unless they got a heart valve done or some kind of infection, right? But the MCV was the giveaway thing, right? Normocytic. So that means that there's nothing wrong with the thalassemia stuff. There's nothing wrong with the actual hemoglobin or the heme or the globin. Those are the two things, right? Microcytic is going to be issues with heme or globin. Macrocytic is usually an issue with DNA. You don't have folate, you don't have B12, some shit like that. Normocytic means that you're just not building it correctly. Iron deficiency can do it. You might have a bone marrow issue. You might have G6PD. Something is causing you to not build your red blood cell in the right shape. And that was ankyrin. (18) 23-year-old woman who is 6 months pregnant develops a DVT. IV administration of heparin is started. 7 days later, the platelet count is 44,000, which is pretty low. Which of the following is most likely responsible for the decreased platelet count in this patient? Okay, so this is a very straightforward question, right? They gave her heparin. Now she has low platelet count. That's HIT. Heparin, a low platelet count is thrombocytopenia. They didn't use the word in the question, because then it would really kind of ring a bell for you. But heparin-induced thrombocytopenia is a very important high-yield topic that you need to know. It occurs because of the development of IgG antibodies against heparin-bound platelet factor 4. PF4 is something that is directly related to heparin. Antibody heparin PF4 complexes activate platelets, and you use up all your platelets now. So you get thrombosis because of the excessive platelet usage, and you run out of platelets, which is thrombocytopenia. This is highest risk with unfractionated heparin. Right, so if you look at all your answer choices, which would also help you, looking at B, you get antiplatelet antibodies, and you're done. Right, but a lot of people picked C, which totally makes sense, right? Heparin-induced hemodilution. What is that? But they see heparin-induced, and they're like, okay, heparin-induced thrombocytopenia, hemodilution, maybe, and then they just lock it in. That's not a way you want to take tests. Heparin-induced hemodilution is not heparin-induced thrombocytopenia, so that's the wrong answer. This is definitely not hypersplenism. This is not a stem cell antibody issue. Antiplatelet antibodies are anti-megakaryocyte antibodies. Well, if this patient had anti-megakaryocyte antibodies, she would have had it the whole time. She would have had it before she even got heparin. This is something new happening after heparin is being given, so she must have made antiplatelet antibodies after the heparin was given. Something happened. Even if you don't know what HIT is, something definitely happened after heparin was given, and this patient started killing off her platelets, antiplatelet antibodies. All right. So you go to page 469. There's something about the difference between two types, right? The fractionated and unfractionated heparin that you really need to know very well. So this image, I've already done the video on this. We're done with Hem-Onc, but this image shows you, right? You have your unfractionated heparin, which is full size, and you have your low molecular weight heparin, which is smaller. The low molecular weight heparin works best with factor 10A, but the unfractionated heparin works really well, as you can see, with thrombin, the 2A. It literally locks it in. It's perfect for factor 2A. You get a ternary complex. It's like they were made for each other. It can also work with factor 10A, but not that well. You can have this portion sticking out a little too much. And this is something they talk about a lot. On the left here is where you have the heparin-induced thrombocytopenia. So you can see how platelets have this PF4, right? You made IgG antibodies against the heparin PF4 complex. This is the heparin holding the PF4. So you have your immune complex. This immune complex causes you to do two things. One, you take away all your platelets, so thrombocytopenia, and you use up a lot of your platelets, causing thrombosis. All right, so that's something that you want to make sure you remember. Heparin has the greatest efficacy on thrombin, which is 2A, because it fits together so well. LMWH, the smaller one, has the greatest efficacy on factor 10A. Heparin works on both via antithrombin. Right, heparin stops both of them, basically. And yeah, that's a pretty big topic. The other guy, warfarin, has its own topic. Warfarin, if you don't do the heparin bridge, then warfarin causes this necrosis. It causes early hypercoagulation because existing protein C depletes. You run out of protein C, and protein C and S, remember, they cut and stop the coagulation stuff, right? So if you run out of protein C, but you still have factors 2 and 10, you end up having hypercoagulation, which is really ironic because warfarin is an anticoagulant. So got to be careful with that. You give somebody warfarin after starting them on heparin first, so you can get rid of protein C and 2 and 10 at the same time. You don't want to get rid of one thing and then keep the other guy's going to win. Number 19, 39-year-old man reports bright red spots on the toilet paper after defecating. Okay, rectal exam shows large swollen rectal veins, hemorrhoids. Which of the following is the primary predisposing cause of these lesions? So what causes hemorrhoids? Constipation. That's it, right? Constipation is the number one cause of hemorrhoids. And constipation can occur to anyone, so you don't really associate hemorrhoids with someone who's only fat or someone who's only skinny. It can occur to anybody, someone that's really, really obese or someone that's very, very anorexic. If they're constipated, they can get hemorrhoids. That's it. Right? Swollen rectal veins on rectal examination are a sign of external hemorrhoids, which are usually painful because external means it's part of your skin, and your skin can feel pain. Right? Somatic pudendal innervation. Number 20, 45-year-old woman has a thyroidectomy because of asymmetric enlargement of the thyroid gland. First noticed during the physical exam 6 weeks ago. She underwent an adrenalectomy for pheochromocytoma 3 years ago. So now that they've mentioned two of these already, you already know this is a question about Men's syndrome. Microscopically, the bilateral thyroid lesions are composed of spindle cells arranged in small clusters. Deposits of amyloid are present between neoplastic cells. Foci of C-cell hyperplasia are also present. The lesions are confirmed as malignant. Which of the following markers is most appropriate to monitor for the development of recurrence of a thyroid neoplasm? So you didn't even need the entire thing. The entire statement was unnecessary. If someone asked you how would you monitor reoccurrence of thyroid neoplasms? Would you look at alpha-fetoprotein? Would you look at ACG, norepinephrine, TSH, or calcitonin? You have to pick calcitonin. Right? Alpha-fetoprotein is related to many things, but definitely not the thyroid. HCG is not related to thyroid, norepinephrine is not. TSH is made by your brain. It comes from up there, so it has nothing to do with a thyroid gland cancer. Right? This patient likely has MEN2, either A or B, due to involvement of both the medullary thyroid cancer and the pheochromocytoma. The patient should have her parathyroid gland removed prophylactically, and she should be examined for mucosal neuromas. Number 21, a 67-year-old woman comes to the physician for a health maintenance exam. Her brother and mother have a history of colon cancer. The physician recommends colonoscopy, but the patient says that she would prefer only for her stool to be tested for blood. The physician explains that testing the stool for occult blood is not appropriate in this case. The physician is most likely concerned about which of the following regarding this test. Super easy question, but a lot of students were very confused actually. Why would we not just order a fecal occult blood test, right, if we're trying to figure out if the patient has colon cancer? Right? Why would we do the colonoscopy instead? Well, if you do a fecal occult blood test, you could see that there's blood, right? You'll find blood, but you won't know where it's coming from. Is it just a tiny polyp, or is it colon cancer, right? Or is it many polyps? It could be any one of these three cases. So the main point there is that you wouldn't really be finding, with enough sensitivity, what's happening. The other thing is, remember snout and spin, right? Sensitivity, snout, if a sensitive test is negative, it helps you rule out disease, and you use that for screening. Spin is if a specific test is positive, it helps you rule in disease. That's for confirmation, right? When you want to confirm, do I have that disease? That's confirmation. Screening is, let's figure out what you don't have, right? That's what we're screening somebody for. So sensitivity tests are used for seeing how many people truly have the disease. Specificity are for those who do not have the disease. A highly sensitive test when negative rules out disease. A highly specific test when positive rules in disease. So that's the snout and spin. So a test with low sensitivity cannot rule out a disease. A test with low specificity cannot rule in a disease. And those are your two answer choices. Low sensitivity, low specificity. What is the physician here most concerned about? The physician is concerned about low sensitivity. Right? Doing a fecal occult blood test is not sensitive enough for the physician to rule out colon cancer in the 67-year-old woman who very well might actually have colon cancer. Right? She has family history of it and she's really old herself. She's above that cutoff line we talked about for age. When you see someone above 65 and below 65, completely different worlds. It's geriatrics after 65, it's normal, and not geriatrics before 65. Right, and then you have the same kind of thing for infants, whereas pediatrics before they become teens. Right, so up to 12, you want to consider pediatric things. Other things didn't really make sense. Right, negative predictive value and positive predictive value are not tests. They're not necessarily tests. They're more of like, this thing when I do it, how likely is it that it is actually going to be correct? Right, so if I get a positive test result, are you sure that I'm definitely going to be positive then, or is there a chance it might be wrong? Negative predictive value and positive predictive value are words that are phrases that really tell you what they're testing. It's the value of that positive test result. It's the value of that negative test result. Is it really good or is it bad? Right? If something has a 30% positive predictive value and I come back positive, I'm more concerned about the 70% that it lacks. So that means that this positive test is probably not that good anyway. I'm hopefully negative. Something like that. So it was very, this question was confusing. A lot of people did pick B. A lot of students I worked with also picked B. But you have to remember that they're doing a screening test. That's the giveaway. They're screening something right now. Right? She just came in for a health maintenance exam. The physician wants to make sure she doesn't have colon cancer. Right? He has no reason to really think that she does have colon cancer. He's not trying to rule in disease. He's trying to rule out disease. That's what we do as physicians. Patient comes in, we're trying to rule out disease, bring it down to maybe 2 diagnoses, and then rule one of them in. Okay? So he needs to rule out colon cancer ASAP because that's a big deal. She needs to get started on the chemotherapy ASAP. So sensitivity. Sensitivity for screening, specificity for confirming after the screening is done. Number 22, a 50-year-old woman is brought to the emergency department by her husband because he found her in a semi-comatose state with an empty bottle next to her. The bottle contained a sodium salt of a drug with central nervous system effects. Of course, they didn't tell you the name of the medication, right? But it's a sodium salt with central nervous system effects. So some kind of medication from antiepileptics maybe. Alkalization of her urine will cause the greatest absolute increase in elimination of the unmetabolized drug if it has which of the following pharmacokinetic profiles. And if you're really weak with pharmacokinetics, you would just skip this question, right? You would pick an answer and just move on with life. But you should still give it a chance. Look at it first. So they tell you first pKa. And you do need to know what pKa is, right? So if you don't remember it, you should, I'll talk about it a little bit here, but you should look it up more. Protein binding in plasma. That makes sense. You know what protein binding is in plasma. So it's either going to be 20 or 98 apparently. So either the protein binding in plasma is going to be low or high. And then volume of distribution at steady state. Either that's going to be low or high. Well, alkalinization of her urine will cause the greatest increase in elimination of the drug if it does not have a high volume of distribution. That makes sense, right? That much is already good. So you just canceled out half the answer choices. So now we're down to A, B, and D, right? If you're going to do, because they're asking a theoretical question. So if they're saying that apparently if they alkalinize her urine, it'll get rid of the drug. But it's going to work best if what is true about the drug. And we don't know what is true about the drug. We're saying hopefully this is what's true about the drug. So in order for a drug to be cleared by the kidney, it must first be filtered in the glomeruli. Drugs with a high volume of distribution have more of the drug in the tissue that are not available to be filtered by the kidney. drugs with high protein binding will not be filtered either, right? So that's why you come down to answer choice A or D. So you want a drug with low volume distribution and low binding if you want it to be cleared by the kidneys in urine. So how do you pick between A and D? Well, then you have the pKa, 6 or 10. A pKa of 4 to 9 can be either weak acid or base. Weak acid, pKa 4 to 7. A strong acid, pKa of 1 to 3. A weak base, pKa of 7 to 9. And a strong base, pKa above 9. Kind of works very similarly to pH. Very similar to that, right? A strong acid has a pH of 1 to 3, right? And so on and so on. Different pHs, well, stomach is 1 to 2, early jejunum 3 to 5, late jejunum 7 to 9, right? Ileum more than 9, urine 4 to 8. Weak acids get absorbed in the acidic environments and cleared in basic environments. Weak bases get absorbed in basic environments and get cleared in acidic environments. You need the opposite thing to clear something out. This does not apply to strong bases or acids, which is very true, and first aid talks about it too. Strong bases and acids are a whole different thing. But weak acids and weak bases, you can clear them out by combining them with the opposite thing. The best explanation for this is a biochem lecture from the past program on this YouTube link. So if you want to check it out, you can. The past program does have a couple videos that are really, really good. I just don't believe in things that are very expensive. Right, but this is a free video on YouTube from the past program where they talk about all of this pKa stuff. So if you want to watch it, you can search for, well, let me show it to you what you would search for, because you can't exactly copy paste the link from my video, but you're going to search for
learn the language.
This guy. Okay, so 19 Biochemistry 1, USMLE past program. It's a pretty nice channel. And this guy's video is very entertaining. I watched some of it too because I couldn't really recall too much pKa stuff. But I would watch it. I would watch this video. Really, really, really good. Oh yeah, I could do that too. There you go. So yeah, I would definitely watch this if you have time. If you have time to learn about pKa a little bit, I would watch it. There's a couple other videos that he has where he's teaching in a classroom session. The only thing was that I wouldn't waste too much time if you don't have time, because some of those videos from the past program are very similar to Kaplan. They take too much time. They progress very, very slowly. But generally speaking, you want to be able to associate pK and pH. You want to be able to understand that weak acids are cleared in bases and weak bases are cleared in acid. Okay, so if you're trying to clear things in urine, well, remember, your urine is not that acidic. Right? Your urine is not that acidic. It is slightly acidic, but not that acidic. And I told you here that your urine is 4.5 to 8. It's not that acidic. So your pKa has to be between that two, which is A. That was the main point here. Okay? So this question, the question doesn't teach you shit, but whatever I put here should really help you understand how you're supposed to use that information with clearance, right? And then in my videos, I've done a really good job. I've already made this video. It's already on the channel. Where is it? Yeah, this thing right here. So bioavailability, volume distribution. I've talked about this perfectly. I've already discussed all of this stuff. You can pause it right here and look at it again if you need to. But how things are distributed and then how they're cleared are directly related to many things. The size, the charge, the lipophilicity, and all of that stuff. So you want to make sure you understand that very well, because you're going to get a question like this on your step 1, 2, and you should be able to tackle it. Number 23, a 22-year-old woman who recently emigrated from rural Mexico is brought to the emergency department 20 minutes after generalized tonic-clonic seizure. She has a 6-week history of headaches, nausea, vomiting, and a decreased visual acuity. Fundoscopic exam shows bilateral papilledema. An MRI of the brain shows enlargement of the right ventricle and findings consistent with cysticercosis. Okay, which of the following is the most likely mechanism of the hydrocephalus in this patient? All right, so cysticercosis, so she got it from eating probably pork or something. And they tell you enlargement of the right ventricle. Only the right ventricle. Okay, so then that's a pretty easy question. It must be at the interventricular foramen, right? Interventricular foramen. Even if you don't actually remember the entire ventricular system very well, when they tell you that the enlargement is only on the right ventricle, there must be something interventricular that's being blocked. So the right ventricle got big, right? There's a right one, there's also a left one, and they're both separate from each other. That's why only her right one is getting big. And let's take a look at what we're talking about here. So if we go back to it, if we revisit it, right? But I just answered the question through just sheer logic. So these are the lateral ventricles, right? You have your right one, you have the left one here, right? In the middle, you have your interventricular foramina of Monro. There's two. There's one for the left and one for the right. All right, so you have your lateral ventricles, you have your foramina, two of them, foramina of Monro. You have your third ventricle in the middle, the blue thing, right? Third ventricle then drops into the cerebral aqueduct of Sylvius, sending the rest of the CSF into the fourth ventricle, which then finally brings it back through the Luschka and Magendie to the subarachnoid space. There's the lateral ones are Luschka, and there's a medial one called Magendie. There's three different guys over here. All right, so foramina of Luschka and one lateral aperture, foramina of Magendie in the medial aspect, and that's it. So with this patient, which one was it? Right one. So only her right one is getting big, and she has cysticercosis, probably mostly over here. She's probably gotten a blockade of her right foramina Monro. So everything in the right one is not draining through the right foramina Monro, and her right ventricle got big. That's it. Okay. You will definitely get a question about the ventricular system of the brain, and you will definitely get something where they ask you where must something be blocked by telling you what was big. Right. So wherever something is big, the immediate door after that is blocked, and this is the flow of CSF. So if one of your lateral ventricles is big, the blockade must be at the foramina Monro. If your third ventricle is big, the blockade must be at the cerebral aqueduct. If your fourth ventricle is big, then it must be a blockade at the Luschka and Magendie. Okay, that's really it. If everything is big, you could also have a lack of your subarachnoid space. Like you might have lost the cells that reabsorb it. The arachnoid granulations, they might have gotten damaged from like a meningitis or something. So fourth ventricle being big can have many different implications actually. So be careful with that. Okay. So this thing, subarachnoid hemorrhage, that would also be something that can cause your fourth ventricle to be big. Okay. Number 24, during a clinical study, an investigator tests a new drug for the treatment of breast cancer. A population of 10,000 patients with breast cancer is recruited and randomized into a treatment group and control group. Analysis of the data shows a p-value of 0.1 and no significant difference in the treatment outcomes between the experimental group and the control group. When repeating the study, which of the following is the most likely to decrease the likelihood of making a beta error? And this is something that you're probably not comfortable with, right? But that's only because you haven't done it much. Before your step one, you want to revisit this topic and make sure you know it, because it's not that hard. It's just you won't always know it. You're not always going to remember it. And there's very small chances you'll remember it even after you become a doctor because it's really irrelevant. But if we go back to page 270, right, this is just biostatistics stuff. You have type 1 error, which is also known as a false positive error. So it's an alpha error where you accused an innocent man. You want to think of it like that. Whereas type 2 error is a beta error. It's a false negative error. Right? So you blindly let the guilty man go free. It's a false negative. You said that that person was not guilty, but they are. Whereas a false positive, you said someone is guilty, but it's false. They're not guilty. Okay, so that's kind of what's happening here. And then that's just half the story. The other half of the story is relating it to statistics, where you have to understand the concept of what the correct result is. Right? The correct result is either you say there is an effect or difference, and the null hypothesis is rejected in favor of the alternative hypothesis, or there is no difference where the null hypothesis is not rejected. Okay, but you never say the null hypothesis is accepted. That's not something you say. That's not a word or a phrase. Okay, can't say that you accepted the null hypothesis. You either reject the null hypothesis or you do not reject the null hypothesis. Just because it's a logical thing. Just because you were able to reject something doesn't mean you have to accept that it's true too. So if you just because you did not reject something, right? If I don't reject the null hypothesis, it doesn't mean that I prove the null hypothesis is true. I just couldn't prove that it's false. Okay? Just because I couldn't prove something is a lie doesn't mean it is true. Something like that. So there is a logical meaning to it. Now, they wanted to know, when repeating the study, what is most likely to decrease the likelihood of making a beta error. How do you decrease the likelihood of beta error? Well, decreasing the likelihood of any error is generally one way to think about it. Increasing the sample size, effect size, or precision of tools will all increase power and decrease 1 minus beta, which is the type 2 error, a false negative error where you say there is no effect or difference even though there really is one. Blindly let the villain go. Right, so if you look at the answer choices, E is increasing sample size, and that's it. You increase power, you decrease error, right? And that's something that they talk about a lot here. See, type 2 error, increase power, decrease beta by increasing sample size, effect size, or precision of measurement. The other answer choices, there was this one, decrease the alpha level. The alpha level is the chance of making a type 1 error, which is really based off of a p-value being less than 0.05. And in our question, the p-value is too high. Right? They tell you the p-value is 10%, it needs to be 5% or lower. That's something you see here too. Right? If p is less than 0.05, we can talk about a type 1 error. Okay? But we cannot talk about a type 1 error if the p-value doesn't fit that. So any alpha value could be just a result of chance alone because the p-value is so high. Right? The p-value determines whether or not something occurred just by mistake and chance, or was it actually significant. Furthermore, alpha, the chance of making a false positive error, is rather independent of beta and type 2 errors. They're really not related to each other. There's no real equation where you relate alpha and beta to each other. Okay? So, pretty interesting stuff. Not exactly something people are fans of, but you're not going to always remember it anyway, so make sure you review it before your test. This is always one of the few things you look at before your test. Biostatistics. Last question for this video, and then I'll come back in like 10 minutes to do part 2. 25. A 13-year-old girl has an episode of severe cellular rejection necessitating maximal immunosuppression 6 months after a cadaveric renal transplantation. Alright, so she got a renal transplant, and she's rejecting it. 2 weeks later, she develops lymphadenopathy and hepatosplenomegaly. Examination of the lymph node obtained on biopsy shows monomorphous population of B lymphocytes, which of the following findings is most likely on the further evaluation of these cells. Okay, so she got some kind of infection with the renal transplant, and with all questions regarding a renal transplant and some kind of infection, you immediately want to think of herpes viruses, Epstein-Barr virus, especially because they helped you. They tell you there's a lot of B cells, right? B lymphocytes are involved. Something about B lymphocytes involved. Epstein-Barr virus is known to lead to lymphoproliferative disease in transplant patients due to their immunosuppression. The other one that's known is also cytomegalovirus. So cytomegalovirus and the other Epstein-Barr virus are both actually really important. And when you look at transplants, let me see, transplant rejection, vaccination, blood transfusion, where's the... Okay, transplant rejection. So, when you look at transplant rejection, where do they mention it? Yeah. They don't quite mention it here. Well, CMV is going to be the one that's related usually to a lung transplant. You'll get a patient with a lung transplant, they'll get CMV infection, and they'll describe the owl's eye inclusion for you in that. But the other thing is, make sure you know this. Organ-specific examples. You gotta make sure you know this. If they describe any one of these things to you, you should know exactly what's happening. So if they tell you, oh, you know, the bronchioles are being destroyed, this patient has chronic lung rejection, right? If the patient is getting accelerated atherosclerosis after a heart transplant, they have chronic heart transplant rejection. If they have nephropathy and they're getting proteinuria and possibly even hematuria, it's chronic kidney rejection. And with the liver, you have the vanishing bile duct. When the bile duct gets destroyed by autoimmune antibodies, that's a sign of chronic liver rejection. Really important to know those guys by heart. In this question, the lymphadenopathy and the hepatosplenomegaly was all a sign of pretty much similar to like what mono would cause, and that was Epstein-Barr virus. That's it. Cytomegalovirus has its own set of things it causes, and none of that was described. Okay, so, but the answer choices is really just between B and C, none of the others. Alright, so that's it for that. I'm going to take a little break, I'll be right back, and then we'll go on to number 26.